Thank you. I'm Philip Chapman. I'm from University of Alabama. I'm the loser of the game show the other night. So, yeah. Well, there's probably 2 or 3 people who haven't reminded me of how smart Pat Hudgens is. So if you want to meet me at the break, the rest of you can chime in. Anyway, so quick history lesson. Let's go back to 1864. General Sherman, the commander of the Army of Northern Aggression, came through Atlanta, burned Atlanta. And when he got to the edge of the city, he met my great-great-grandfather, Thaddeus Chapman, who said, "General Sherman, you look like shit. Can I get you a drink?" And that's how we saved the city of Savannah. They decided not to burn it down because of that relationship. But it turns out it was middle of December, so General Sherman sends a note to Abe Lincoln and says, "Well, you know, Abe, I've captured the city of Savannah. I'm giving you the city of Savannah as an early Christmas present." So, fortunately, it never went anywhere. But I think UPS tried to deliver the package, like a few weeks later, and Abe Lincoln wasn't at home to sign for it, so he didn't get it. He was at a theater or something, and never quite managed to get it. But anyway, that was my opening joke. It didn't go quite as good as I was hoping, but
we liked it.
Okay, thank you. Thank you. Who are these guys? No, I'm just kidding. Okay, so we've got 5 categories instead of 5 cases, and we'll try to get through as many as we can. Hopefully show 3 or 4 cases under each category. You know I like CTAs and things we miss on CTA. We've discussed that here before, especially incidental extravascular findings. Everybody knows it's a perfect storm, right? A lot of these cases we're reading from the ER standpoint. There's an increase in these number of CTAs for stroke and trauma. These are complex studies, thousands of examinations. The search is intense, it's deliberate. We're focused on the arteries, and we're often time pressured. I've calculated it to be 0.18 seconds per image when we're looking at these in the ER setting, and we're going to rely on these mental shortcuts or heuristics to try to make it through the day. So let's look at our first case, number 1. This is a 75-year-old with head trauma, and of course they come to the ER. They've got a little bit of subarachnoid hemorrhage, so of course we have to do a CTA of the neck and a CTA of the head to make sure they don't have an aneurysm. Well, what was noticed here is this little bit of atherosclerotic plaque in the right common carotid artery. So the report says moderate stenosis on the right, no aneurysm identified, and the neck soft tissues are normal. So of course, either the good thing is the radiologist is at least thinking about the soft tissues of the neck, or his template is thinking about it, right? And some people think that that's even more important these days. So. But look what was missed here. Here's a large infiltrating mass in the right neck, and you kind of look at this and go, gee, how do you miss that, right? There's the vessels. How do you miss this large, ugly thing there? But this turns out to be, of course, metastatic squamous cell carcinoma to a level 2 node, and it certainly looks like it has extranodal or extracapsular extension as well. And listen, if you've been in a car wreck and you've got a missed cancer, you're going to the head of the line at the lawyer's office, okay? Because the legal sharks are circling this case, right? They love it, okay? But this is a classic inattentional blindness. It's there, we're just not paying attention to it. And this term was coined in 1998 by a rap group, Arian Mack and Irvin Rock, a couple of PhDs. But Mack said, I'm convinced there's no conscious perception without attention. And that's kind of interesting. There are a lot of articles out now that deal with this process of how do we think about taking a study from perception to actually dictating the report. One in radiographics, one in AJR, this one by Busby, and this slide was loaned to me by Christine. But one of the things I would add is, maybe there's a different component that has to start even before this, and it's the component of attention. And we have to look for ways in which we can improve it. One of those ways may be artificial intelligence, right? Maybe have some sort of mechanism that tells us what to look for, points out something. Templated reports might remind us to look, and that's helpful if we actually look. And then, of course, what we're doing here this week is we're learning how to increase our fund of knowledge, learn how to do these search patterns better, and then et cetera, such as, I don't know, maybe get off of Facebook, something like that. Here's another case, 65-year-old with trauma, neck pain. Look, you can see there's a fracture of C1. Okay, so let's do a CTA. And lo and behold, the right vertebral artery is out up in the head. We look down below, and there's sort of a classic tapering. So this is an acute dissection of the right vertebral artery with occlusion. So we should be pretty happy here. But look what was missed. Necrotic lymph nodes in the left neck, levels 2 and level 3. So this is more of a complex miss, right? There's something hiding in plain sight, just like the other case, but also there's probably some satisfaction of search, right? Acute trauma, we've got a fracture, we've got vertebral artery dissection. What else do they want from us, okay? It's in the ER. But the patient comes back 4 months later. Now it's an outpatient setting. We're kind of relaxed. We're drinking coffee and go, whoa, what do we see this thing right here? And again, we've got a metastatic squamous cell carcinoma. This is another case that comes a little bit of a different route. It comes through tumor board. You can obviously see there's this very large oropharyngeal carcinoma, necrotic adenopathy, big bulky lesion. And of course, this study was done when the patient had painful swallowing. But looking in the medical record, 3 months earlier, they'd come to the ER for transient ischemic attack and had a TIA. Now, maybe you don't see this quite as well, but all this was completely missed on the CTA. Again, we're focused in on this big, bright white spot here and just sort of overlooking the soft tissues here. Here's another patient. Now, sometimes we've got to be careful about overcalling things, and I want to see what you guys think about this. 54-year-old, it's 9 p.m., trauma, neck pain. Okay, let's get a CTA, and here it is. We'll just kind of march through it. Notice there's a lot of motion. The airway's partially closed anyway, like the patient's breathing or having some kind of respiratory difficulty, maybe choking, whatever. So as we follow through, we'll see what you think. I see a lot of motion, and I'm not satisfied with this study at all. I'm not sure I would call anything in the soft tissues. I probably would have said, hey, let's recommend a repeat study. I don't know. Maybe some of you saw a cancer. I don't know. But let me show you how it was dictated. So there's 2 pages on the report on the vessels. They're normal. Then this. There's a heterogeneous soft tissue fullness, possible mass, supraglottic region with possible transglottic extension. I'm like, whoa, really? You know, how many think there was a cancer? You're right. So there are motion artifacts, and they actually recommended repeat CT examination with soft tissue and laryngoscopy, okay? So we know from a recent article in European Journal of Radiology from Crockett et al. Regarding these incidental findings on CTA, that look at the yellow here, 20% of the patients with highly clinically significant findings did not receive appropriate follow-up. So that's what we find in incidental findings in general. We sort of don't know what to do with them, and the doctor doesn't necessarily follow up, and we may not have a system in place that actually helps protect that patient and keep them from falling through the cracks. So what was done in this patient? Well, the trauma surgeon actually sort of cut and pasted the entire report into the history of physical, okay, in the body of the report, 2 pages, boom. And then gets to the impression there's no mention of it, there's no plan, and there's nothing in the discharge summary. And the patient was never told about it. Okay, so you say, well, who knows, may not have been anything there in the first place, right? But the patient returns to University Hospital 6 months later. Now he's got hoarseness, now he's got a sore throat. And as we kind of march through this, look what's going on. Uh-oh, there's a necrotic node, the epiglottis is thickened. Lo and behold, that reader was correct. There is something there. In fact, it's a very large supraglottic carcinoma with bilateral adenopathy, okay? I've got a lot of images, I suppose, in this case. I wanted you to see the full everything, okay? So this is obviously a large carcinoma. This is me applying my artificial intelligence in the yellow here. I'm waiting on the grant, just color in the tumor. But this was obviously not missed, but the system failed to ensure that this patient got a proper follow-up. And again, the sharks are circling. And so how are we going to avoid it? Again, we got to do a primary search pattern, look at the vessels, and then we got to stop and treat it like a soft tissue neck and look at all the other extra vascular findings, including the skull base and the bones. Okay, let's go to another category, post-operative and post-treatment neck. This is very difficult. Amanda Corey gave a great talk on some of the flaps and everything. It's just an amazing talk, and it's just 20 years too late for me to learn anything about it. But I call these the LOL cases, right? Not laugh out loud, but leave on the list, right? You open up, like, nah, let's just leave this one on the list, Yeah, right. Just leave that for Hornsberger or somebody, But what I would say is this. I try to keep up with a lot of the errors in my own section. I try to learn from them. We try to share them in quality conferences and whatnot. And I have my own folder there called My Misses, okay? And I know we're in the South, but that's not girlfriends. That's just my errors, the things that things I've screwed up on, okay? My wife found that, and she's like, what is this? I said, you can't look at that. What do you mean I can't look at it? It's against the law. It's patient information. Yeah. Anyway. But here's the point. 75% of my own misses that are in this folder are head and neck misses in this category: post-operative, advanced cancer, post-treatment changes. It's very difficult, even if you do it every day, even if you call yourself an expert, even if you think you're smart at it. It's very difficult. Okay, so I'm going to show you some routine misses just to show you that you can miss routine findings. So this 65-year-old with advanced oropharyngeal carcinoma. He's had a glossectomy, he's had a laryngectomy, you can see a tracheostomy tube here, and this is just a small little lesion here in January. Now this is their first follow-up. I didn't read this one, but I did read this next one a month later. It's probably gotten a little bit larger. I didn't notice this little nodular enhancement, but this is where they should be, right in the operative bed. Most of the primaries are going to recur right there, and especially if you have a fat flap, look on the bottom of that, look at the base of that, follow that around. So that was a little nodular enhancement, and I didn't mention it, thought it was the same, but 3 months later, it enlarges, and this is what we're looking for, right? Newer progressive nodular or mass-like enhancement. That's what I'm thinking as I'm looking at these studies. So again, it's a small lesion, but nonetheless, I should have recognized that it was larger than it was in January, and we should have gotten it. Here's another case: a 55-year-old male with a history of epiglottis cancer now presents with a very large left neck mass. And I'll just show you 3 images, but there's 50 images of this big thing over here, and this person is looking at me like, "You missed that?" No, I didn't miss this thing. Come on. Gee whiz, I'm not stupid. But you can see obviously there's a large mass. It's infiltrating all the soft tissues, and I'm going to spend a lot of time thinking about the carotid, examining the carotid, the prevertebral soft tissues, and obviously describing the skin invasion. So obviously it's a T4 lesion. So what did I miss? Well, what I missed were these little subtle areas of lucency in the upper thoracic spine. They're clearly there once you put red arrows on them, and this patient went on to have some compression fracture but no neurologic deficit. So again, you say, well, how important is that? Well, we don't see a lot of bone metastasis, and it only occurs at about 1% of head and neck cancer, but in these advanced cases, that's where you need to look for them. And so I usually reserve that as the last thing I'm going to do for a tumor case, is look at the bones, put it on bone windows, and especially look in the spine, okay? Review those bone windows, especially if you're dealing with a cancer outside of the head and neck that may have metastasized to the head and neck. If they've got nodal disease, you better look for bone disease. Here's just a case with a big, giant lymph node in the supraclavicular region, but what was missed were lesions in the manubrium as well as the cervical spine. Now remember, missed bone lesions, they could certainly cause pain and suffering, but when you have spinal metastasis, you may end up getting compression fractures, cord compression, and neurologic deficit, right? And when you have neurologic deficit, that's a special kind of chum for the legal sharks, okay? There's another case, a 52-year-old with squamous cell carcinoma of the epiglottis, had radiation therapy, then had recurrent disease, then had a laryngectomy. So I'm looking through this, and I won't show you every image, but I'll show you a lot of them just to kind of get a sense of, boy, these are hard to look at. They're hard to get a sense of normal anatomy. And some of you are probably right now seeing what I missed on that left side, but you can see there's a nodule of tissue here. I just blew by it, completely missed it. Maybe it looks like submandibular gland. Maybe that would be my argument. I'm not sure, but it's certainly a nodular area of enhancement that shouldn't be there. Here in the coronal plane, notice that that's almost plaque-like. It's sort of, flat going across, not like a normal anatomic structure, certainly not acting like a normal lymph node. In fact, this is probably extranodal. So sometimes these things are sort of non-anatomic, and the usual locations, the usual shapes, and the usual boundaries don't apply when the fascial planes are disrupted. Here it is 3 months later as it's enlarged, and now it's become fully manifest as a recurrent tumor. We'll go to another category here, and Ginsburg talked a little bit about this, perineural tumor spread as it relates to occult tumor, and in this case we're going to talk about occult parotid lesion. So obviously what we're talking about, tumors that start in the parotid gland, and typically they travel in retrograde fashion up the mastoid segment and into the temporal bone, and sometimes into the IC. This is just a classic one. This was not missed, but you can see there's a lesion in that posterior medial parotid, and then tumor extends superiorly through the mastoid segment up and over and into the IC, and you can see the axial views there. But I think there is a blind spot that Larry mentioned, and I also see it in my own practice, where sometimes we just don't see this parotid lesion, or sometimes it's not in our field of view, and sometimes it's not even been included in the study at all. And I think there's a few other issues. Number one, it's difficult anatomy. As we come out of that external auditory canal, it's really easy to sort of dismiss that area because it's complicated to look at. Tumor may have a similar density on CT as regular parotid. It may have similar intensity on on MRI, depending on the sequence, it may have similar enhancement. And the other thing is sometimes we just get wrapped up into the Bell's palsy assumption. We say, well, we're just looking for a little bit of enhancement at the genu, and once we declare that or not, we move along. The other thing to remember is that the radiologic workup may focus on the IEC. So what we do is we do these 3 millimeter slices, and about the time that we get to the parotid, we stop, okay? That's part of our deficits. The parotid can also be omitted or just overlooked or not included. So let's look at a case. 73-year-old with slowly progressive facial nerve palsy, had an MRI scan done about 9 months earlier, and we look back at this, and sure, there's this nodular lesion right here in that posterior medial parotid, and there's where the facial nerve ought to run, so it's easy to see how this might affect the facial nerve. Here's the top of it, and you can see it looks like it almost contacts that neurovascular bundle of facial nerve in the stylomastoid foramen. Here's the abnormal side. Here's the normal side where we have neurovascular bundle in the stylomastoid foramen right as it enters the mastoid segment, and there's a full layer of fat all the way around it. Here it is on T2. Here it is post-contrast. It's not dramatic, but certainly we have these red arrows that makes it stand out. But look, 9 months later, this is very aggressive. It's blowing out the posterior medial parotid now. It's enhancing, and the sharks are circling, okay? Here's the perineural tumor component of it. It goes up to the stylomastoid process and extends up to the mastoid segment to the posterior genu. This was an adenoid cystic carcinoma. Here's another unfortunate case, 78-year-old with 9 months of right-sided facial weakness diagnosed with Bell's palsy. So we're 9 months out now, and I'll just show you this was described as asymmetric enhancement, but it's still 9 months out. That's a little bit unusual for Bell's palsy, and he's not recovered any function, so we got to consider something else. So I saw this in retrospect, so I said, well, wait a minute, let's look down the parotid. There's a little nodule, same location, posterior medial, right near the stylomastoid area. So here it is post-contrast. Sometimes enhancement can camouflage it. Now you've got enhancement in the lesion, it just disappears. Here's diffusion restriction, so there is some diffusion restriction in this small lesion. So that was in December 2015. 6 months later, he comes back, another MRI scan. Now it's enhancing a little bit more. Now this is interesting. So we get down, and the reader said, well, you know, it's a little bit worse. Maybe it's worsening Bell's palsy. That was the first thing that came out, right? Now, I didn't laugh, but I thought, I've never heard that before. Okay. So, but they also did include that could be a schwannoma, could be perineural tumor spread. So I think that was good, but there was no mention. If we look down a little bit further, there it is. There's the lesion that's gotten larger in the posterior medial parotid, right? So in my world, this certainly could be a schwannoma, but in my world, it's an aggressive malignant parotid carcinoma until proven otherwise. So these two studies were done. I saw it because I was going to not write a paper, Jesus, not me, but I was going to do a talk on facial nerve paralysis, pulled out these two cases, looked at this. I sent an email to the neurologist and the neurosurgeon and said, hey, I think this patient has a parotid cancer. I think this is perineural tumor spread. And they say, you're too late. And I said, well, what do you mean? He said, well, we've already done a cable graft procedure on this patient. We've put a nerve from the hypoglossal nerve to the facial nerve to reinnervate the face, and that didn't work very well. In fact, it didn't work at all, and the pain has progressed, and they really didn't want to believe me, okay, because they've gone and done this big, expensive procedure on somebody that might have cancer. Now, they've struggled with this for 3 or 4 years now. This is what it looked like in July. Now the tumor is spread up, and it's just starting to take over the posterior fossa, okay? So this turned out to be, they finally did surgery last month, salivary gland adenocarcinoma, okay? Another theme, another case, same theme. 41-year-old, this patient presented slightly different TMJ pain. That's what it was described as. It morphed into trigeminal neuralgia. Multiple outside studies, the patient saw multiple doctors. Then they developed a left-sided facial nerve paralysis. So just like Dr. Bunch's case, I think 3 days ago, this is very, very similar. Initial non-contrast MRI of the brain study was done in 2017, and I'll just say, look back retrospectively, maybe there's something here. This is a difficult area. We know there's a lot of venous plexus here. It's tough. I'm not saying anybody's going to call that, but maybe there's something there. This patient had the unfortunate luck of actually having this persistent trigeminal artery. So they got this, and they said, oh, that's why you're having the trigeminal problems and all this pain. Here it is on MRA. I'll let you look at it. So they were sent to UAB really for the possibility of neurovascular decompression. The neurosurgeon said, wait a minute, we haven't explained the facial nerve paralysis. So we got another MRI scan, and this is some of the, you just saw this beautiful illustration from Dr. Curtin, but this V3 is thickened. Again, this is the lateral pterygoid muscle. I call this the football field. V3 is important, so he's at the 50-yard line on the home side. This is away side. You can always find it right there. It's a little bit thickened, and then there's this thickening going back, right? So we know what this is going to be, right? This is the auriculotemporal nerve. We've had it discussed here before. Here's just a nice drawing of that, and this is a good depiction on the T1, and here's that lesion down here in the parotid. So we also did a post-contrast, not that pretty, but you can see enhancement of the nerve, not just enhancement around the nerve, but enhancement of the nerve going back along the auriculotemporal nerve and joining up with that lesion in the parotid. You can also see this on CT scan, not quite as well, but if you know where to look, there it is, a big thickened V3. This one's hypo and dense with peripheral enhancement. This one's enhancing centrally. We could follow that down. There's that tissue now. It's enhancing more. The CT was done after the MRI, and there's the lesion in the deep parotid. So what's happened here, deep parotid tumor started out, got on auriculotemporal nerve, TMJ pain maybe, then V3 trigeminal neuralgia, and then ultimately a year or so later involves the facial nerve. So nice demonstration of that, and this is the diffusion restriction of that tumor. Another lesion similar in the way it happened, squamous cell carcinoma with external auditory canal. Again, this is very difficult to see this tumor, okay? I can do my AI on it. I can draw a red circle around it. Now you see it a little bit better, right? Okay, and there's the tumor going up to the stylomastoid foramen. As the tumor heads up, you can see that enhancement better on this post-contrast MRI, and we can just follow it up, and you know where it's going. It's just going to sneak right up to the mastoid segment and ultimately normalize. So, 4 minutes left. We'll talk about the next category, missed lesions in the oral cavity. So I find this to be very difficult. We recently did a study a few years ago looking at some T1 and T2 lesions, and about 33% of those in our own shop were missed in one way or another. So it's a commonly missed problem. We're not mucosal doctors, but I do think we can find a lot of these lesions if we look for them, if we are not in a situation where we have the history. Here's a missed floor of the mouth cancer. I think everybody can see that as it's enhancing nodular tissue in the floor of the mouth, starts to involve the oral tongue, and the report said no discrete mass, lesion, or adenopathy. But what difference does it make? Well, I think if we know where the lesion is, we're certainly going to apply those questions to a greater degree. We're going to look for the involvement of the bone, cortical irregularity. We're going to look harder at those nodal stations, and we're going to obviously look for the submucosal extent. So I think it is important, even though, again, that classic saying, we're not mucosal doctors, but I think we ought to be able to see these enhancing lesions. What are the pitfalls? Well, the mucosa is redundant. The mucosa is enhancing. So we're trying to find an enhancing tumor in the setting of this redundant enhancing stuff called the mucosa. And often these mucosal surfaces are opposed. And keep in mind, there are multiple subsites of disease that we have to know, we have to think about as we're going through our search patterns, particularly if we're not given the exact location in the history or the medical record. So again, a number of multiple anatomic sites that you've learned already, but you just have to use those. You have to think about those as you're going through it, your search pattern. And also think about the variable morphology of mucosal lesions, not just in the oral cavity, but everywhere. Obviously, we like to think of them as something, a mass rising up off of the mucosa into an airspace, but it can also be more three-dimensional. It can be submucosal or infiltrative, and it can also be penetrating or ulcerative, so there's actually volume loss. These are more difficult to kind of get the residents to look for in our shop. Here's an example of a missed case, 82-year-old with a painful lesion in the anterior floor of the mouth. That's the history. The clinic note says there's a 3-centimeter lesion in the anterior floor of the mouth, and they've even biopsied in squamous cell carcinoma, but somehow we just go by all that information and say, well, there's a solitary lymph node, and there's no abnormal enhancement of the mucosa, and I think everybody in the room can see this very large anterior floor of the mouth tumor that involves the cortex of the bone and deeply infiltrates the anterior aspect of the tongue there. And obviously, we've got artifacts in this region we have to fight through, the dental amalgam, the dental appliances, the dentures, et cetera. I think with this case, you could probably find it if we just force ourselves to look through the artifact here. And we do additional techniques at our shop, as most of you do. Butterfly technique, puff cheek technique, particularly for looking for buccal carcinoma. And here's a patient, 66-year-old female with tongue swelling and pain. You can see multiple lymph nodes here that we can see. And this was what the report said, bilateral cervical adenopathy. Again, these are heterogeneous. They're less than a centimeter, most of them, but they certainly look malignant. No primary tumor identified. But look what we have here. It looks like a starburst pattern, disco lights. I admit, this is a hard one to look at, and it sort of reminds me of this guy, back in the day, I'd like to have some music, but I just don't. But remember, we have to pay attention to things. Don't get distracted by bright lights and disco things. But look what was listed. If we come up out of that tumor in the oral tongue, there's a large area of enhancement that was completely missed on this examination. Obviously, PET scan is helpful in revealing that lesion to us, but it takes up 2/3 of the tongue. So we have to know what normal morphology of the tongue looks like. Here's another patient that presented with adenopathy. The malignant nodes were clearly noted, but there was no evidence of the primary tumor. But then we said, well, maybe there's some fullness over here in the oral pharynx instead. But if you kind of fight through the artifact again and think about those multiple sites, even if you don't know where the history is or you're not given the history, you can see some thickening here in that buccal space. And this is a missed buccal carcinoma on a patient that you can see that clearly on the coronal view. So last case, I see asymmetry of the tongue all the time with 7 seconds. This is kind of interesting. You've all seen this, and it's an error that keeps repeated all the time. Necrotic appearing soft tissue mass involving the left tongue concerning for tumor. I think most of you would recognize that as simply denervation injury of the tongue, but these asymmetric tongue lesions tend to continue to be quite a bit of problems. So in conclusion, I think we got through at least 4 of the 5 categories. The last category was simply lateral sphenoid meningoceles, and I was going to present that just because in my shop we've had 3 different radiologists miss 3 different lesions in 3 different circumstances in the last 12 months or so. So it is something that sneaks up on us both in epilepsy and not so much in CSF leaks because we're sort of zeroing in, but in epilepsy for sure we'll miss those cases. So hope you enjoyed it. Thank you so much. Appreciate it.
Thank you, Dr. Chapman. All right, our next speaker will be Dr.